Welcome to this explainer. We've got a lot of ground to cover today. So, over the next hour or so, we're doing a comprehensive deep dive right into the childhood mind. We'll be looking specifically at how psychiatric and developmental disorders present in our earliest years. It's a complex but literally absolutely crucial topic. And since we are taking the full hour to really get into the weeds today, we're skipping our usual summary at the end. Instead, we're going to make this clear, accessible, and totally memorable right from the jump. Let's get to it. Here is our clinical roadmap for the hour. First up, intellectual and developmental disabilities. Then, autism spectrum disorder. After that, we'll unpack ADHD and finally look at behavioral and physical disorders. All right, diving right into Section 1, intellectual and developmental disabilities. Now, when we talk about intellectual disability, we're not just ticking off a sterile clinical checkbox. We have to look at it empathetically, as a state of arrested or incomplete development of the mind. The key marker to remember here, this impairment has to manifest during the developmental period, specifically before a kid turns 18. It's an incredibly broad impact, right? It touches cognitive reasoning, language acquisition, motor skills, and social abilities. It fundamentally alters how a young person processes the entire world around them. So what does this actually look like day to day? Well, these clinical definitions translate into profound real-world challenges. To actually diagnose an intellectual disability, we're looking for what we call adaptive functioning deficits. Think tangible hurdles in reasoning, planning, and problem solving. But it goes way beyond just struggling with academics. It deeply impacts how a kid communicates and participates socially. Ultimately, these are deficits that limit a child's capacity to live independently. It means they're going to require ongoing, sometimes lifelong support just for standard daily activities. To put that into perspective with some numbers, intellectual disability affects roughly 1 to 3% of the overall population. And you'll notice here it actually occurs a bit more frequently in males. When we dig into the root causes, genetics play a massive role, like a huge piece of the puzzle. Down syndrome, or trisomy 21, is the most common chromosomal cause out there. Meanwhile, Fragile X syndrome, which, as the name implies, heavily affects that X chromosome in males, is the most common genetically inherited cause. Moving right along to our next early onset condition, Section 2, Autism Spectrum Disorder Explained. ASD is another condition that presents really early, usually becoming super clear before a child even turns 3. Diagnosing it is kind of like looking at two sides of a coin. On one side, you have profound interpersonal hurdles. We're talking impaired social and emotional reciprocity, like maybe an inability to hold a typical back-and-forth conversation, alongside deficits in nonverbal communication, like notably decreased eye contact. Then flip the coin. The other side is all about restricted, repetitive patterns of behavior. This might look like an incredibly intense focus on, say, the spinning wheels of a toy car, rather than playing with the car itself, or a totally inflexible adherence to very specific daily rituals. Because literally every child on the spectrum is unique, treating it requires a real multi-layered approach. Early diagnosis is just a total game changer here to unlock their full potential. The foundation? That's usually behavioral training, relying heavily on positive reinforcement and social skills management. Next, we layer in specialized therapies. Think speech, occupational, and physical therapy. And then, if needed, on the medical side, we can use pharmacological supports for related behavioral hurdles. Things like alpha-2 agonists to help tone down hyperactivity, or FDA-approved low-dose atypical antipsychotics like risperidone. All right, let's keep this hour moving. Section 3, Understanding ADHD. Now this brings us to how kids interact with environments that demand sustained focus, like a classroom. The prevalence of ADHD is honestly pretty striking. We're looking at an overall rate of about 12%. That is a lot of kids. And while it gets diagnosed way more frequently in boys, it's absolutely crucial to remember that girls often present very differently. Girls usually show more of the inattentive symptoms, excessive daydreaming, forgetfulness, instead of that classic climbing the walls hyperactive behavior we usually picture. And honestly, that difference is exactly why girls' diagnoses are so often delayed. Okay, time for a quick pattern interrupt. Myth busted. I know you've probably heard the rumors going around that too much sugar, terrible diets, or random food allergies cause ADHD. Well, the clinical source material hits the nail on the head here. There is absolutely zero scientific basis for those claims. None. ADHD is fundamentally rooted in genetics and minor brain dysfunction. It has literally nothing to do with what a kid ate for breakfast. When we actually look at how we treat ADHD, there's a very clear clinical hierarchy. First-line treatments are typically your stimulants, like methylphenidate or dextroamphetamine. And look, they work incredibly well to boost attention span and concentration. But there's a catch. We have to monitor them closely because they can seriously decrease a child's appetite, which obviously might inhibit their physical growth. If those aren't tolerated, we pivot to second-line, non-stimulant options like atomosetine. And of course, the whole shebang has to include non-pharmacological treatments. Psychoeducation and behavior modification are absolutely essential pillars if we want long-term success. So that covers attention and cognitive development. But what happens when a child's primary challenge is externalized? What happens when it's explicitly behavioral and highly disruptive to everyone around them? That big question brings us to our final chapter for the hour. Section 4, Behavioral and Physical Disorders. Now, things are escalating from attention deficits to issues that really disrupt societal norms. The crucial point here is understanding the stark difference between two conditions that get confused all the time: oppositional defiant disorder, or ODD, and conduct disorder, or CD. A child with ODD is highly argumentative. They deliberately annoy people, and they carry around this deeply angry, defiant mood toward anyone in authority. But here is the hard clinical line. Unlike conduct disorder, ODD absolutely does not involve physical aggression or violating the basic rights of others. Once that line gets crossed, now we're looking at conduct disorder. This has about a 9% prevalence and, again, is much more common in males. The signs here are severe and they are recurrent. We're talking about active physical aggression toward people or animals, deliberate destruction of property, like setting fires, deceitfulness, theft, and really serious rule violations, like running away from home before they're even 13. Clinically speaking, this is an incredibly serious pattern, largely because it's heavily associated with developing antisocial personality disorder later in adulthood. Shifting gears from behavioral to physical conditions, let's map out Tourette's disorder. Chronologically, Tourette's follows a very specific path. The onset usually hits between ages 4 and 6, and it's driven by a dysfunctional regulation of dopamine in the brain. The tics themselves, which by definition must include multiple motor tics and at least one vocal tic lasting for over a year, usually hit their peak severity right around ages 10 to 12. It's a chronic condition that kind of waxes and wanes, but understanding this timeline, it's a lifesaver for caregivers trying to anticipate and support a child through those really difficult peak years. Last up today, we have the elimination disorders. These actually require specific developmental age markers for a diagnosis. So enuresis, commonly known as bedwetting, isn't diagnosed until a child is at least 5 years old developmentally. Encopresis, which is fecal incontinence, requires the child to be at least 4. The great news is treating these relies heavily on highly practical interventions. We use bladder training and limit nighttime fluids for enuresis, or we utilize stool softeners and bowel training for encopresis. Doing this lifts an absolutely enormous psychological burden right off the kid's shoulders. We've spent this hour really digging into the details, and as promised, we aren't going to just summarize and tie this up with a neat little bow. Instead, I want to leave you with one incredibly provocative thought to chew on. How will our understanding and our early intervention of these childhood conditions reshape the adults they ultimately become? By breaking down these complex disorders today, we aren't just putting labels on childhood struggles, we're actually mapping out the profound interventions that can completely alter the trajectory of a human life. Thank you for joining me for this explainer, and keep asking those big questions.